Okay. So I think fever, when a patient, any child comes with fever and altered sensorium, it becomes a medical emergency for us, right? So we will be focusing on how to approach this child. So we suppose we have a 3-year-old who comes with fever for 3 days, altered sensorium since the morning, and when on examination you find that the child is having altered BCS and some meningeal signs, then obviously the first diagnosis all of us I think would make is a bacterial meningitis. So we'll start with Dr. Harsh. In a situation like this, when a patient comes with fever and altered sensorium, there are many terminologies which are used, like meningitis, encephalitis, and encephalopathy. Would you like to define these terminologies for the audience?
Yes, sir. Familiarity with
ये ले लो.
Hello. So familiarity with this terminology is very important. So if we concept you, the encephalopathy is a very broad term. It involves everything. So any child or any patients present with any alteration of behavior, consciousness or sense of awareness, which is encephalopathy. Encephalopathy has a many causes ranges from infectious, non-infectious, toxic, metabolic, everything. When we terms encephalitis, then we are very specific. We are incorporating the infection or inflammation as a cause of encephalopathy. And meningitis is a more specific term when we are thinking in terms of there is an inflammation of meninges or meningeal layer, which results into the whatever the presentation of this child having the fever and altered sensorium.
So any of the other panelists would like to add anything for the definitions? You're okay?
Whatever the encephalopathy is what we clinically see actually. Encephalitis, when we have evidence of all, taking into consideration of investigation, all these things, we can call it as encephalitis.
So as you can see, these kind of cases require a little bit of good clinical history and examination to actually define what is meningitis, encephalitis, and importantly, encephalopathy. So we'll come to the next question for Nikhil. How would you differentiate between an acute or a subacute febrile encephalopathy?
Now, this acute febrile encephalopathy, good morning everyone. So acute febrile encephalopathy, initially the term was coined by the government for Japanese encephalitis. It was initially Z. So when we are defining acute febrile encephalopathy, it is usually a very short duration, and the duration has been defined as 14 days. So any encephalopathy with fever, with altered sensorium, or any CNS infection, CNS which presents in less than 14 days, we term is as acute. A subacute febrile encephalopathy is, we see it very less in pediatrics. It is more common in adults, but some cases like SSPE or metabolic encephalopathy or any metabolic or immunodeficiencies, they may present with subacute. So usually the differentiation is only with the time, and acute would be less than 2 weeks, and the subacute would be more of in the duration. It may be in weeks. So it's the.
So is it important for the etiological diagnosis?
Yes, etiologically the acute ones are more like viral, bacterial, or which are very rapidly progressing one. A subacute one may are usually related to organ failures or maybe related to very chronic infections like TBM or this thing. So etiologically also it is very important to differentiate both of them.
Yeah, so I think in our setting we should always have TBM in the background if we have a subacute, but of course it is known that even TBM can present with acute presentations. So we'll go to the next question for Dr. Siva Prakash. What is the most common etiology you see in tropical countries? Like for instance in India?
Hello. Good morning to all. If you know acute encephalopathy, what are the causes, what organism causes? it depends on the geographical area of the world. Even in India, it's maybe because of, maybe we can divide into different pattern, like probably because of the infective cause or non-infective cause, like that. If you come to the infective cause, which is more commonly we come across in our practice, it's mainly again it is divided into maybe a viral, maybe a bacterial, parasitic, and etc. If you come to the viral, is the most of the time virus is the cause, common virus you come across. Again, the government of India again it divide into GE encephalopathy, non-GE encephalopathy also. So non-GE is one of the important, especially in some particular areas. If the patient is coming from there, we have to suspect that. Non-GE, again, whatever we come across virus, it may come with the encephalopathy, maybe a dengue, maybe a malaria, maybe sometimes a rickets cell fever. So many organisms, even the viral, we have seen even H1N1, influenza, adenovirus, we have seen encephalopathy, even the corona also contributed encephalopathy. So most of the time, organisms are viral, any virus, commonly whatever the prevalent in that particular geographic area, we have to suspect, and also that season what virus is there. In that particular thinking, we have to suspect. Anyway, it is a non-virus etiology. So many are there. We starting from toxicology, like a drugs, like a poison, maybe a bite. So many things are there.
So what about if suppose you have to give, like, for this audience, that common, we know infections are common still in India. So what is the common bacteria and common virus you've already touched on?
Yeah. So bacteria, we know that pyogenic bacteria, tubercular encephalitis is very common. Again, the if you come to the bacteria, pneumococcus and even Hib. Nowadays, the Hib is reducing because of the vaccination. Even over the period, pneumococcus may come down, but as of now, pneumococcus should be suspected. And also, tubercular meningitis as a capital city of TB. We have to suspect a TB also one of the cause.
So basically,
And also enteroviruses. Very commonly we come across. We forget common virus is the enterovirus. Will not get the diagnosis many a times.
so I think the message from this question is that if you are in, suppose, Northeast India and in my state, probably I would think of JE first, and then you even have non-JE causes, but bacteria is still there in spite of the universal coverage of the vaccines. We know all over the country we are giving now pneumococcal vaccine also, but still we do see cases on and off. So, Dr. Vasant, what are the common clinical features which these patients usually will present with for the postgraduates, if you can highlight?
Yeah, usually clinical picture depends on whether it's a meningitis or whether it's encephalitis. Totally different. Suppose it's a meningitis, in neonate, you get patient with uncontrollable fever, seizure, that irritability. You may get hypothermia or you may get hyperthermia. But if child is more than 28 days, then you get typical all these signs along with seizure, but you get vomiting, headache, photophobia. This is the classical difference. You may get neck stiffness in child more than 28 days, but you usually don't get neck stiffness in neonate. And if you take the example of you want to consider encephalitis, then encephalitis goes step by step. Usually, child present with a high grade fever, delirium, irritable talk, and that get progress. Slowly, there is a repetition of seizure, and patient may go to coma level.
Any of the other panelists would like to add or supplement his Nikhil?
So the clinical features vary from age. It may vary from etiology. So whenever you are looking at infective causes, they usually start with fever and altered sensorium. It may vary from just amnesia to mild syncopal attacks to altered sensorium to coma. But when we are looking at a non-infective causes, they may present initially with all the different presentations like vomiting, mild headache. They may not present with fever. Even the age group differs. So if in the neonate, as sir has said, they may present, and as we progress, they may have a different. So seizures is one of the thing which is a very critical thing. So presenting with seizures is usually we get in our emergencies are those with presenting with more with seizures.
So I think this is a very important message that if you have fever with seizures, then you must think of a CNS infection. Thank you very much. So, do all children present with meningeal signs?
So I think we all know that. Hello. So as we all know that all the children are not presenting always with meningitis, have all meningeal signs. Younger infants and neonates, the only altered sensorium or altered behavior, with along with fever, we should think in terms of CNS infection, especially in the younger infants. And even those who are vaccinated till the age of 1.5 to 2 years of age, they may not have all the signs of meningeal infections. They're very subtle. They present with this kind of symptoms. Even the viral fever at aseptic meningitis, most of the patient doesn't have a proper meningeal sign. So whenever you have a fever with altered behavior, altered sensorium in the presence of seizures or any focal deficit, definitely you have to think in terms of CNS infection, and you have to try to investigate the child accordingly.
So, I think sometimes when you have children with malnutrition, they also may not have meningeal signs. So, in the clinical context of a malnourished child, you must always suspect meningitis or rule it out. So, what are the causes of febrile encephalopathy with meningeal signs?
Febrile meningeal signs. So what is important? Meningeal signs are usually there when there is an inflammation of meningitis. The simple thing. So anytime the etiological thing is involving the meningitis, you will get the meningeal signs. There are different methods for meningeal signs, and we all know that on clinical examination. What are the causes? So it would be a simple meningitis, it would be meningoencephalitis, or it would be uh, acute disseminated meningoencephalitis. So if we see these would I would say these are the more of the localizing definition: meningitis, meningoencephalitis, and now these are overlapping syndromes. You don't get a simple meningitis. There might be a component of encephalitis. You don't get a you get if it is a metabolic cause is there, you get more of encephalopathy than encephalopathy. So for me, the etiological things are overlapping. So what we need to see is it is more of the infective causes which will cause meningitis and meningoencephalitis.
So, first we'll think of infective and then we'll keep non infective in the background. So, again, Dr. Shivaprakash, I think you've touched on this, but if you could again say without meningeal signs, we already
Yeah.
discussed, but there are some, yeah.
I think it's already very clear. The meningitis may be, with encephalopathy may be with the meningeal sign or without the meningeal sign. If you ask what are the cause for without the meningeal sign, already clear disease, most of the kids, children and infants, we cannot see the meningeal sign. And whatever we see many times acute febrile encephalopathy, which are mostly a viral cause, we may not see this meningeal signs. So maybe HSP, maybe dengue, whatever it is, whatever the virus you take that. Many non-infective cause, that is also they are not present. Like suppose a toxic encephalopathy, vaccine encephalopathy, maybe drug-induced anticholinergic, or maybe something systemic infections, or maybe a organ failure like uremia, all these things, and ODM like autoimmune conditions. You may not see the most of these non-infective conditions. You will not see the any meningeal sign. And of course, in the kids, most commonly is the virus will not see the meningeal sign.
So I think what we are just trying to tell you here is that if there is a patient with an encephalopathy with fever, you could have a wide variety of causes. So not only stick to infection, but you must always think of, particularly now that we have a lot of vaccines being used, the most common causes of bacterial meningitis are being taken care of by immunization. So when you have a patient like this, your brain must also focus on if it could be something non-infectious. So many of these, as Dr. Shiva Prakash and the others have highlighted, many of these can have non-infectious etiology. So what about the immunocompromised individuals, Dr. Vasant? Is there any particular organism that we should think about
The
or
most-
look for?
Yeah, most common immunocompromised childs are who are gone to for splenectomy, those are diabetic or HIV. So they are commonest infections are one is the fungal. They can go to tuberculosis. And if you're thinking of bacterial infection, step pneumonia and Listeria monocytogenes, they are the commonest causes.
Any other causes you'd like to rule out?
Whenever we are dealing with immunocompromised, even the bacterial infection, they present into a very broader spectrum. So whenever we have a immunocompromised patient, we think of brain abscesses, fungal infections. So here we have to, why we need to know these organisms is the investigation wise and the treatment wise. We need to be very aggressive. So we can't be this thing. Even the rare like Cryptosporidium, these are which are not seen routinely. We have to suspect them. And whenever you get a CSF sample, we should ask for the special stains for them too.
Yeah. So I think he's hit the nail that when you have an immunocompromised patient, your CSF sample, when you send it to the lab, you must inform the pathologist that this is what you're suspecting, because then only they will do the special stains and give you the organism. Otherwise, everything will come negative. So very well said, both of you. So, Harsh, any important points in the history that you want the postgraduates and our audience to ask about in such cases?
Most of the time, to decide or to arrive at the conclusion of CNS infection is not that much difficult. Usually you have fever, headache, the classical trial. The younger infants also sodium, lethargy, or there is a seizures or any focal deficits you may have. But the more important points in the history along with that are also we need to look upon the possible etiologic factors. So in the current, if the child has a current febrile illness, then child will remain stable for another 2 or 3 days, and then again landed up with a flurry of seizures or posturing or something like that, then definitely triggers in your mind that it could be para-infectious or post-infectious immune-mediated phenomenon. So we can look apart from the non-infective causes along with the which is triggered by the infection. That is also very important thing. The second thing is that sometimes the child may have a diarrheal illness or oral ulcer which can point towards a certain viral etiology like enterovirus. In certain geographical areas, as ma'am said, that northeast or even the Bihar and the surrounding the UP areas, they have very more common etiology as a Japanese encephalitis. Those can also help us to decide upon the possible etiologic factor. And usually in our textbooks also that mention, Dr. Fenichel has beautifully mentioned, there are two ways, high ways and the low ways of coma. So usually when the bacterial infection child present with the lethargy, decreased activity, decreased feeding, which is a low way, and usually the viral infection are presented with a very agitated behavior, rowdiness, we can say neuropsychiatric manifestation in the initial half, then flurry of seizures and posturing, which is a high way of coma. So these are could be the probable etiology and also help us to even streamline our possible investigation with the available resources and in acute settings to decide upon the how fast we can act in a best way to offer the treatment.
Any other opinions?
History is very important even for the history and examination. The examination part, sometimes the patient may have a rash. It may give the some clues. So maybe a dengue, maybe if you see the SR, maybe a ricket cell fever. Or maybe sometimes the patient present with the maculopapular rash like a measles or mumps, like a nowadays we are seeing a lot of mumps cases also in Bangalore. So like unilateral parotitis. So we can suspect something like that. Like organomegaly is there, we can typhoid also one of the organism, even for the dengue also. Involvement of the liver is there, maybe a dengue, maybe leptospira. Like this, we history will give the more information for the diagnosis. The history and examination is the paramount important when evaluating for the investigating the thing.
So I think what we are getting at here is that you have to take a background history. The epidemiology is very important. So if you are in UP, in West Bengal, in Northeast, then are there many cases like this happening? So which would indicate a Japanese or a JE-like illness. Then rash, which Dr. Shiva Prakash mentioned, I think is very important, because we know fever with rash with meningeal signs, probably you're dealing with meningococcus or some other rickettsial illnesses. Then there are other non-infectious causes or systemic diseases which can also present with sometimes CNS infection or CNS involvement. So, like SLE, we have a rheumatologist sitting in the audience, and I think he'll really mind it if I don't say that if it's a female child, please also take the history of any past problems which the child had, because sometimes, especially in the adolescent period, you can have a girl presenting with encephalopathy with fever and it could turn out to be a SLE. So, these are very important points in the history. Particularly the epidemiology, in many cases are occurring at the same time, then you can really reach a diagnosis just based on the history. So, Dr. Nikhil, what about the emergency? This is febrile fever with altered sensorium is a medical emergency. So, just can you outline the emergency management in these patients briefly?
So again, we have to go back to the basics of path. So first, when you receive a child, the first initial thing would be the maintenance of airway, breathing, and the circulation. So airway, we have to see if the child is maintaining the airway. If the GCS is very poor, the child may, on admission, require immediate intubation, ventilation. Uh, Same thing for circulation. So anytime you receive the child in emergency, you have to look for the blood pressure, look for the peripheral pulses, the CRT, and start with fluid boluses and inotropes as and when required. The other thing would be important is the looking for the sugars. So whenever you get a child in emergencies, always look for an RBS, because these babies are usually septic and they may present with hypoglycemia, which may exacerbate their uh, CNS manifestations. So the more important would be the A, B, C, looking at hypoglycemia. From treatment point of view, you will start with the basic investigations. You will put an IV line, put a big, large bore IV line, collect the samples, and send the appropriate investigations at that time. As far as the drugs which are required, is the first thing we need to see is treat hypoglycemia. The second thing, if a child has presented with convulsion, the initial treatment with a benzodiazepine and loading up with the anticonvulsant, appropriate anticonvulsant. It may vary from center to center, but a appropriate anticonvulsant. The next thing would be starting an antibiotic and antiviral and an anti-malarial. So while we are discussing more of the viruses, there are multiple areas where there is a cerebral malaria is more common and the child may present with fever. So initially in the emergency department, starting with the first dose of antibiotic, anti-malarial, and acyclovir. The third thing would be if there are signs of raised ICP in emergency, you can start with decongestive measures uh, like a dose of mannitol or a 3% NS, and we can wait. So if you see, the more importance would be to stabilize the patient, shift him to the ICU, and then once the patient is stabilized, we can go for the further management like neuroimaging and CA.
Excellent. I think he's taken up most of the points. So, the issue to be highlighted here is that you stabilize the patient, maintain the ABC. Investigations can wait. The only investigation which is important when you first get the patient is to do a sugar and find out if the patient is hypo, U, or hyperglycemic. So, thank you, Nikhil. And I think he has outlined the management as per the Government of India guidelines, where it is said that you have to give an antibiotic, the first dose. You give acyclovir because that's herpes encephalitis is the only treatable viral encephalitis, and also in malarious areas you would give a anti-malarial agent. So, Dr. Shiva Prakash, now that we have stabilized this patient, what are the investigations that you would like to send?
Yeah, this patient is taken, the history, examination is done, neurological examination is done, emergency treatment is given, what to give. Now let us come to the investigations. Yeah, sir already mentioned actually, GRBS is very, very important because most of the times hypoglycemia, especially in the younger age group, may be present with encephalopathy. We should look into that. Second thing is basic investigation. Depends on your epidemiology, depends on your history, depends on your examination. Let us have a basic examination. After the basic investigations, we can go for the further. Suppose in the CBC, we can send for the CBC, we can get RDT or peripheral smear for the malaria, RT for malaria. Sometimes rapid tests for the dengue we can send. other tests, even the wheel Felix, if you are suspecting for the rickettsial fever, or other basic investigation we can have. Later on, we can go for the further investigation. So, very important investigation in any encephalopathy is the LP, cerebrospinal fluid analysis. So, before that, prior to doing that LP, we are make sure that patient don't have any rise intracranial tension. That should be make sure that by doing the imaging or some taking the precautions. So we should do that. So in that actually CSF is the one actually gives the clue because the patient is developed encephalopathy means already that whatever the blood level investigation possibility may reduce actually. So we have to take the more CSF analysis is a paramount important that can be said do for the even the routine investigation on the cell count, the cell typing, all these things can be sent, culture can be sent. And also very important is nowadays is the PCR testing and the panel, ES panel is available. So we can send for the ES panel including the HSP, dengue, even other organisms also included. So depends on that we can do the PCR test so that we can get the specific. Sometimes we can get the even the multiple investigation positive. So most probably you have to compare with your clinic and you can take up to the what are the most common possibilities. Of course, other investigations like a CT, MRI can be considered. For that depends on the condition. Of course, the EEG should be considered wherever it is available, especially if the non-convulsive status epilepticus, or if you are not able to find any other cause, or specifically if your EEGs helps in diagnosing the patient with the HSV encephalitis because of the
So what about the serum electrolytes? Would you give importance to that?
So and also not only this basic investigation actually told even the RFT and serum electrolytes. Serum electrolytes may be a hyponatremia, other metabolites abnormality also we have to look into that.
Yeah. So important is you look at the serum electrolytes, particularly sodium, because many of these patients may have conditions like SIADH or cerebral salt wasting or diabetes insipidus associated as a part of the disease, and that's the only way you will be able to find out. So, Dr. Vasant, since Dr. Shiva Prakash has said that we'll do an LP, so any contraindication? So we can do LP in all the patients.
Look, any serious infection, LP is a gold standard, but there are few conditions where you have to delay LP, and as soon as patient is stable. Suppose the patient is unstable, like patient is in a coma, patient is in a decelerate rigidity, or you can take the question track, that is the bradycardia, hypertension, and irregular respiration, and patient Glasgow coma scale is below 8, then you have to avoid.
So raised ICP is one situation where you will avoid, and also another situation is suppose you have a thrombocytopenia. So you want to say something? Yeah.
Disorder, a severe thrombocytopenia, a very low GCS, and a raised intracranial pressure, which may cause herniation.
Herniation. So these are the things that are to be remembered. So Dr. Harsh, she has already said a few tests. Considering that now we have so much of availability with us of different kinds of biofires and things like that, what are the CSF samples that you'd like to send for or maybe keep for future analysis?
So the procedure itself, while doing CSF, the opening pressure itself can tell you whether there is increased pressure or not. Even the appearance of the CSF, certain hints in certain situations. And if you come to the parameters of the CSF testing, the routine is very important. So your sugar, protein, and cells are very important thing. Especially whenever possible, if you have a kid with suspected meningitis or CNS infection, and if there are no contraindication is present at the time of presentation, and the child is antibiotic naive or is not received any treatment, then better to go for a CSF first if feasible, because it's very important to differentiate between the possible causes, possible etiologies on that first sample. And whenever you have a relative less pheocytosis with high amount of hypoglycemia, that means low sugar, your sugar is just less than 15, less than 20, less than 10, and your cells are only 150 or 15 or less than 500, and your patient does not receive any antibiotics present to you, then it's a itself very suggestive of you have to think in terms of tubercular meningitis in our scenario. So these are very important features of the basic CSF testing, as well as CSF culture is also important. We have to also go for, as Madam has discussed, now the BioFire and multiplex PCR are very easily available. And although they are a bit costly, but still now they are coming into the affordable range. So that help us to characterize, to know the possible etiologies of the various common viruses, fungi, and as well as the bacteria. So I think these are the very important things we can look into the, or we can gain from the CSF.
And always keep an extra sample in the fridge, because you might have to send it for something else. You cannot keep on repeatedly doing a lumbar puncture in these kind of patients. So I think that is an important thing, that you may have to send for some serological test or something else later on.
So if autoimmune encephalitis is suspected, only CSF anti-MMDA is required. Rest other tests can be done from the serum.
Nice. So what are the indications of doing a neuroimaging now, Dr. Nikhil? Will we do it in all patients?
So as important as CSF is there, neuroimaging is also important. So whenever a child is presenting to you in an emergency, in a critical stage, what is first important is to stabilize the child. Even for an LP, I would say that LP is not always required. We can start with the empirically a complete this thing, and then we can do the LP, and even the same for the neuroimaging. First stabilize the child. Now uh, a neuroimaging is required in all the children. So what we decide is which would require in an emergency. So any child who has deteriorated rapidly, any child who has focal signs or a focal seizures. Why is important is whenever there is a focality, there is usually some SOL or something which is affecting the brain on a unilateral side. And there are signs of raised ICP. So whenever you are seeing the child is having bradycardia, hypertension, there is a decerebrate or a decorticate posturing, or any signs which are pointing towards a raised intracranial pressure, first a neuroimaging should be done before doing a CSF. So, uh, uh, so as far as the question indications are, all children with a CNS thing should get a neuroimaging. A neuroimaging, if the child is very critical and is not able to go through a complete MRI, then now the MRI takes 40 minutes. So to get a complete neuroimaging for an unstable child, MRI is very difficult. So in these cases, a CT would be preferred. Now, CT has the advantages that it is
So
rapid.
we'll discuss that later on. So what is the message from here is that in a sick child, you probably would go for a CT because it hardly takes more than 5 minutes, right? So Dr. Shivaprakash, now you tell me why CT or why MRI? Patient is stable. Now I want to do a neuroimaging.
Yeah. If you ask me or you, anyone, which one is best? But in this patient, especially cerebral encephalopathy, the best investigation is MRI, because we'll get the very clear information and also severity, extent, everything we can get that. But CT is the most commonly available, widely available in our point of whatever the care near to that. So in that actually CT, though it is there is a radiological some hazard is there, but still widely we can use, especially in our resource limited setting. So where before doing LP, because we have to rule out, as we mentioned, that intracranial tension. So we have to get the CT, and also sometimes in a patient of immunocompromised or a patient with the severe papilledema or a severe unconscious or abnormal unconscious, the CT is a mandatory before doing the LP. So that is very, very important. Though CT is gives immediate investigation, not taking much time, and also by enhancing by contrast, by using the contrast, the meningeal enhancement will get, abscess will get, even sometimes any other basal skull lesions, all these things we can get from the in the bed. The CT is best even for the sometime when we send for the CT, usually there will be the diffuse axonal injury, something like that, with the traumatic is there. Something they will get that from the CT. Whereas in MRI, So it is it takes a lot of time. The time consuming, costly, and also in very difficult in a resource limited country like India to get the MRA for all the patient to get. And sometimes we cannot do the MRA for the unstabilized patient, and by doing the MRA, the patient can be unstable. This is also possible. So in this actually MRA, though it is a good by the cause and the extent, especially with encephalitis, the clear encephalitis pictures can be get from the MRA. Especially a diffusion weighted images will give the very clear picture, especially HSV encephalitis, sometimes what is that, herpes, varicella, cerebralitis, all this which are even for the sometimes we can get the enterovirus features specific to that. We can get very clear extent. And also sometimes if you are having the dealing with the ADM or necrotizing encephalopathy, all these features very clearly we can get from MRA. Only thing is MRA is very costly, very difficult to do, and it time consuming. Sometimes because of this sedation, maybe complication of the sedation, aspiration, many things will occur. Very difficult. Very best investigation once the patient is stabilized, or if you want to identify the what is the cause or something like that, it is the best. Otherwise, in an emergency, CT is the one investigation is advocated. In non-emergent conditions, you can. Yes, but the thing is, within 24 hours, if you do the in any patient in encephalitis, at least some things we can get the information. Of course, in a further, even a spectroscopy also can be done. MRI spectroscopy depends on condition and complications of sometimes meningitis can be identified, strokes and other thrombosis. All these things can be identified.
So the message from this discussion is that in all cases, probably CT is the one which you will do first. And if you are suspecting that your patient is not responding to a usual way of treatment, maybe an edem or things like that, then you would probably go for an MRI. So very briefly, Doctor, can you tell me when to order for a contrast study?
So the answer covered by Dr. Zosle. So if we are suspecting any infarct, tuberculoma, then you should go for a contrast study. Best is the MRI with contrast study as compared to CT scan, because there is a good meningeal enhancement you can see.
So either it's TBM or abscess, then we will go for a
Yeah.
contrast study. Okay, so I think we've already touched this, Dr. Harsh. Did you want to say something with these images? Yeah, if you.
So these are the images are showing the picture of tubercular meningitis. So any patient, when we think in terms of CNS infection, and provided there are no contraindications to the contrast, then contrast is desirable. It will help us to delineate certain basal exudate and something, early hydrocephalus and everything is visible in tuberculous meningitis. I want to give only one message that for bacterial meningitis, the contrast enhancement is not a surrogate marker of bacterial meningitis. It depends on the acquisition of the images when it is taken, the amount of contrast is given by the radiologist. So there are many variables which counted for the contrast enhancement. So bacterial meningitis is a clinical, we can think in terms of the clinical as well as CSF finding. The contrast is required, or the bacterial meningitis, the MRI is useful to delineate the complication of that meningitis. So subdural or subependymal abscesses, or there is brain abscesses, something like that. That are the main indications for the, help us to go for the imaging in this bacterial meningitis. And the complication, as madam has mentioned, the ADM and the sometimes this is a very classical case of anti-NMO positive patients. He has a very classical involvement of the cerebellar peduncle and the midbrain, which are very particular area for NMOSD patients. And sometimes we see the ANEC, acute necrotizing encephalopathy, especially with dengue, even corona, and even the H influenza also we are seeing. It is the subsequent, these are the very peculiar finding in swan images when we can say the blooming, which is a marker of hemorrhages.
Thank you. Briefly, can EEG tell you the etiology?
Yes, so when there is a PLEX, that is a pleomorphic epileptiform changes seen in EEG, we can suspect an HSV. More important, the EEG will tell you the CNS status. nowadays, whenever you are getting a child with encephalopathy, you should do an EG to look for whether there is a diagnosing nowadays is FIRES, that is a febrile infections with resistant epileptiform seizures. So these things, when we are looking, it is more important to get an EG. Even an autoimmune encephalitis presents with some characteristic EEG pattern. So EEG, though may not give you a large spectrum, whenever it is used, it will help you in the diagnosis of etiology. And
Thank you. So metabolic causes, Dr. Shiva Prasad.
Yeah. So very, very important, whenever the patient presents the recurrent encephalitis, if you are not able to find any cause, especially in the early age group, infant or something like that, we should suspect the metabolic cause. So we should, the samples, we have to take the sample before starting the treatment and before stopping the feed. So we should take the sample. And the third one is sample, we have to take from the blood for the ammonia, lactate, ABG we can take, and other TMS we can send for the dry blood sample for the TMS. So depends on that, we can do that. So because delay in the taking the sample does not prevent the treating the patient, treatment also should be started simultaneously. What treatment will not give any other treatment specifically. The non-specific treatment of multivitamin and the cocktail treatment can be given to the patient.
So last question to Dr. Vasan before we end.
Yeah, as per Nikhil already covered everything. It is immediately stabilization, anti-convulsant, antibiotic, and once your
So
result
what is the most common antibiotic that one would usually use?
most common antibiotic is ceftriaxone.
Ceftriaxone. And the antiviral, as you said, is
Acyclovir.
And for malaria, what would you suggest?
Artesunate.
Artesunate. So I think we'll just thank you so much to the panelists. I will just end with this brief algorithm, I would say. If you have any patient with fever and altered sensorium, as we have already discussed, first is ABC followed by blood sugar. Manage the blood sugar as per the sugar levels and always send the lab value because your dextro stick may not be reliable. Then you manage the fluids, the ICP and the seizures in the child. Then go for a detailed history and examination. If there are focal signs and signs of raised ICT, always go for neuroimaging first. If there are no focal signs, you can do an LP with CSF analysis. And in the meantime, also rule out dengue, malaria, and enteric fever. And then go for the management where I think this is got stuck. So we look at the electrolytes, we look at the other investigations and manage as per we have discussed today, that the antibiotics, the antiviral and the antimalarials till we get our results. Thank you so much for a very active discussion. I hope it was beneficial to all.